Acute diarrhea is defined as 200 grams per day of stool dry weight. You probably are not going to get someone to poop in a bucket and measure their dry weight of stool, so we use a more clinical diagnosis. Diarrhea is defined as an increase in frequency or a decrease in the consistency for whatever is normal for that person. So there's no cutoff for number of times per day or how loose it has to be. It just has to be different from that person. What you should do is begin separating all diarrhea by time. Less than 2 weeks, acute. Greater than 4 weeks, chronic. There's a crossover in the subacute phase between 2 and 4 weeks. The idea being that most acute diarrhea is going to be infectious, and most chronic diarrhea is not going to be infectious, some sort of medical disease. In the subacute phase, it could be either one. So for this, we're going to talk about acute diarrhea, less than 2 weeks in duration, almost certainly going to be infectious, knowing that the most common cause is a self-limiting viral gastroenteritis. Let's start off by talking about the different organisms you have to know about and some of the risk factors that come with them. So when you see someone with an acute diarrhea, which means less than 2 weeks, you want to separate it into enterotoxic and invasive. Invasive sounds nasty, right? It's like the bug is going to bore its way through the mucosa, get into the tissue. And if it gets into the tissue, it's going to break things apart and cause some bleeding. And the body's going to notice it, right? Because it broke down the blood-gut barrier. And now the body's like, whoa, there's an infection. I got to go get it. That's exactly what happens. So in an invasive diarrhea, what you're going to see is blood. So it's a bloody diarrhea associated with fever and leukocytosis. The body notices. And there will also be fecal white blood cells. This points you towards an invasive organism. On the opposite side of the spectrum, when an absorptive gut gets turned into a secretory one, it is not because the organisms have gotten into the tissue, it's because there's a toxin floating around. And this is going to present with a watery diarrhea, without fever, without leukocytosis, and without fecal leukocytes. I want to point it out because it might come up. Fecal leukocytes are actually not that sensitive. If you really wanted to get a test to say, is this an inflammatory diarrhea or not, the test you would use is a lactoferrin. Not routinely done, but if you really believe that this is an inflammatory or invasive diarrhea, you'd want to get a lactoferrin. But these are two types of diarrheas. The watery diarrhea, where it's not systemic, that doesn't have any fecal leukocytes, and then the one that is systemic, it's going to be a real infection and set up shop. And for each one, you have to know the organisms that are associated. For enterotoxic, C. diff, enterotoxic E. coli, Vibrio cholera, Staph aureus, Bacillus cereus, and Giardia. For the invasive ones, you're looking at things like Salmonella, Shigella, enterohemorrhagic E. coli, that's O157H7, Campylobacter, and Amoeba histolytica. Now, this is not a comprehensive list, but this is a list of organisms that are commonly tested, and in the vignette will be some sort of risk factor that the person gets exposed to, if you know what that risk factor is. In real life, a individual person will have exposure to multiple risk factors in a 3-day period. And since most incubation periods are between 6 and 48 hours, you can't really know what the tipping point was. Now, if someone gets sick at a picnic Could be anything. They might have gotten sick before the picnic. But if 12 people get sick at a picnic, then you can trace the disease to that picnic. The point being that you will not know what organism is infecting your patient in front of you if it's an isolated patient, because they will have had multiple exposures up to that point, and likely it's viral. But you still need to know the associations. C. diff is associated with recent antibiotic use. We'll talk more about C. diff. Enterotoxic E. coli is traveler's diarrhea, Montezuma's revenge. Look for Central America. Vibrio cholera is transmitted fecal oral, and usually it's going to be in contaminated water. So look for third world countries and no boiling water. Staph aureus is proteinaceous foods. And this is a toxin, not the infection itself. So look for the picnic with the egg salad or the potato salad that's been left out all day. B. cereus is reheated rice. Look for Chinese food buffet lines. And Giardia is associated with camping, fresh water. In the invasive organisms, Salmonella is associated with chickens eating raw eggs or uncooked poultry. Shigella and enterohemorrhagic E. coli are associated with the hemolytic uremic syndrome. And E. coli is associated with uncooked meat. Campylobacter is the most common cause of invasive bloody diarrhea that's infectious overall. And for Entamoeba histolytica, look for a severe immunocompromise, specifically HIV/AIDS. Have to commit those to memory because they're going to be on your test, but just recognize that in real life, you won't know what's causing the infection based on the history alone. So then what do you do when someone comes in who has acute diarrhea? So if someone comes in with acute diarrhea, your job is to decide, do I get the tests? And we'll see what those tests are. The first thing you ask, is this just a regular old viral gastroenteritis? Most of the time, if someone is vomiting from both ends, vomit and a lot of diarrhea, it's gastroenteritis. Almost always, it is going to be a viral gastroenteritis and not one of these organisms. And all you have to do is wait it out. So if yes, it is just a regular old viral gastroenteritis, all you have to do is rehydrate and wait. Ideally, you would rehydrate with oral route, but sometimes they may not be able to, so they get IV. And you can use loperamide. In a viral gastroenteritis, there's no harm in keeping the stool in. The diarrhea is not flushing out toxins or getting rid of the virus. It is just symptomatic and it sucks for the patient. So slow down their diarrhea and rehydrate them. The times when you should think, this is not just a normal gastroenteritis that's self-limiting, I need to do something about it, is if they have red flags. And those red flags are high fever, severe abdominal pain. And this isn't just, oh, my tummy hurts, I feel better when I have a bowel movement. It's really bad, it looks like peritonitis or a toxic megacolon. The person is immunocompromised or has recent antibiotic use. They've been hospitalized. It's bloody diarrhea or there's obvious pus. There are severe electrolyte derangements or the duration has been greater than 3 days. These are signs that, hey, I need to do a little bit more investigation on this person, and usually they're going to be the reason when someone gets admitted to the hospital. Even if just for an observation stay, you want to make sure it's not something more sinister. But the decision to admit is based on their illness, their severity at presentation, not necessarily the presence of these. These tell you, I need to do more. To do more, the first thing you're going to do is C. diff. We'll talk about the different tests you can do for C. diff. We talk about C. diff specifically. If it is C. diff, diagnosis is done. and you are going to treat. Your options are metronidazole, orally, vancomycin, orally, metronidazole and vanc, that's IV and PO, fidaxomicin, that's PO, and fecal transplant. I blew through those because we're going to talk about them more when we talk about C. diff, but just know that there's a large variety of options that you can choose from to treat C. diff. If the C. diff is negative, and you need to do more investigation, this is where you look at the stool studies. What's going to happen is that most of the time, if on an inpatient service, if someone meets one of these criteria, you're just going to get all the studies all at once. That's to save time. That's not how the path of clinical reasoning works. If the C. diff is negative and you're worried that it's more than just a viral gastroenteritis and they might actively be infected, what you do next is get stool white blood cells and stool reds. And remember, it could be the lactoferrin. So if you do have red blood cells and you do have white blood cells, you're looking at an invasive organism, and you want to get a stool culture and a colonoscopy. Because if the stool culture is positive and the colonoscopy is negative, you have an infection and you treat with antibiotics. If the culture is negative and the colonoscopy is positive, you have your first medical disease. Your first presentation of a medical disease. And that is going to be discussed more in the chronic diarrhea section. But on the other side of this, right, this is for invasive, there are red blood cells and white blood cells. This is why you do some more invasive testing. If there are no white blood cells and no red blood cells, you're dealing with enterotoxic. And here, even though it normally has a very low utility, the ova and parasites are obtained. Because if positive, it's a parasite. You treat with antibiotics. It's negative. It was just viral to begin with. And do the same thing for them here. Treat them symptomatically, rehydrate. Okay, so what I really want you to see on this is that most of the time, gastroenteritis is self-limiting. Don't do anything. If someone comes in with a gastroenteritis and isn't septic, doesn't have a fever, doesn't have leukocytosis, don't give them antibiotics. Just hydrate them. If they're really sick, they look septic, then yes, pick antibiotics. But for the most part, it's going to be don't give antibiotics and only do these studies when absolutely indicated. Don't do them routinely. They usually yield nothing. And one more time, you might see someone get stool cultures, white blood cells, red blood cells, and ova and parasites all at first. In practice, it saves on time, but generally you should not be doing that because the test has so low yield. Okay, this is how we approach acute diarrhea. Let's talk about two causes of acute diarrhea that you need to know in greater detail. The first one is C. diff. This one you should really know about because it comes up all the time on every rotation. C. diff lives in your gut. Everybody has C. diff. But when C. diff has overgrowth, generally as a response to systemic antibiotics that kill off the rest of the gut flora, C. diff predominates and the disease occurs. The patient normally presents with a watery diarrhea, with a telltale smell. In order to diagnose C. diff, you get a C. diff. Now, it used to be a C. diff toxin, and you had to get that 3 times. No longer. We have a better test, which is a C. diff nucleic amplification assay. You might remember getting a colonoscopy from step 1, seeing a pseudomembrane. Well, if you did a colonoscopy not thinking it was C. diff and saw the pseudomembrane, great, it's C. diff, but you do not want to do a colonoscopy in C. diff. And the pseudomembrane does not have to be there in order for it to be C. diff. So that's wrong too. You just get the C. diff nucleic amplification assay. And here's the way this works. You always have C. diff. But when you have diarrhea and your stool tests positive, you treat it. You don't treat solid stool, positive C. diff. If you don't treat diarrhea, negative C. diff. Only the combination of watery diarrhea and C. diff do you treat. And treatment goes something like this. For all intents and purposes, oral metronidazole is equal to oral vancomycin. But because vancomycin is more expensive, you're going to want to pick oral metronidazole. So the first time they have their occurrence, oral metronidazole. The second occurrence, you give oral metronidazole. But you can also use vancomycin, but don't because it's more expensive. If they come back again, use fidaxomicin. You'll never see this used in practice because it's too expensive. And for refractory cases that never go away, there's a fecal transplant. Yes, indeed, this works to cure the patient of C. diff. But there will be a time where vancomycin is the right answer. Because if this person had the water diarrhea and smelly one, all they're having is some diarrhea, no big deal. But if they also had fever, leukocytosis, megacolon, by exam or by CT, tympanitic, tender, and renal failure, that is the BUN and creatinine are elevated, this is severe C. diff, and severe C. diff is treated with oral vancomycin and IV metronidazole. You attack it from both ways. Vancomycin cannot cross the blood-gut barrier, so when you ingest oral vancomycin, it just sits in the lumen and it kills off whatever's there. IV metronidazole can cross the blood-gut barrier, and so you give it intravenously, so it attacks it from both sides, intraluminally and extraluminally, and it eliminates the C. diff faster. But you only do this combination when there's a severe presentation. And I want to briefly touch on hemolytic uremic syndrome, which is in the spectrum of thrombocytopenic thrombotic purpura. The path is going to be EHEC 0157H7. The patient is going to present with a bloody diarrhea after eating uncooked meat, have renal failure, and have anemia. I'm briefly touching on this because it's a popular test question, but it's not really useful for adult medicine. HUS is usually seen in kids. But every once in a while, every 5 or 10 years, some fast food restaurant doesn't cook its meat well enough and E. coli gets introduced to the population. So it becomes a board favorite. Uncooked meat, bloody diarrhea, rise in the creatinine, fall in the hemoglobin, think of HUS. But you're going to look at it and say, well, hang on, he's having a bloody diarrhea, so that explains why there's anemia, and they're just having lots of diarrhea, so they're probably volume deplete. That's why they've got acute kidney injury. No, this is a microangiopathic hemolytic anemia. The diagnosis is made first by getting a blood smear to confirm microangiopathic hemolytic anemia by looking at schistocytes. You can confirm HUS caused by 017H7 by getting a sugar-like toxin assay. The treatment is mostly supportive. If they go into renal failure, dialyze them. If they're volume deplete, give them fluids. If they're down in blood, give them blood. But if this is HUS or TTP, what you need to do is plasma exchange. All right, I glossed over that because it's very small, low yield, but easy to get points on. What I really want you to focus on instead is the approach to someone with acute diarrhea, who you actually need to do something for and who you don't, and when you do the workup and when you don't, and then focus a lot of your attention on C. diff. That's acute diarrhea.